Hi everyone, my name is Dr. Ruth Arumala and I am an obstetrician gynecologist practicing in Mansfield, Texas. I am also an assistant professor in OBGYN at TCU UNT Joint School of Medicine. It's a new medical school in Fort Worth, Texas. And today I want to talk to you about normal labor and delivery because this is a fundamental thing. It's a fundamental topic that you need to know about before you get on labor and delivery as a third-year medical student, acting intern as a fourth-year medical student, or right before internship. You need a refresher course. So I think we're going to get into it. We're going to learn a lot, and I'm going to share my screen. Okay. So normal labor and delivery is so important because you have to know what is normal before you can understand or recognize when there's a problem or where there is an abnormality. So what I want to cover today is not super comprehensive, but it's going to be an amalgamation of my experience and what is in the textbooks. So you can get a robust feel of what you should be looking for and what you should know before you get on labor and delivery. I will be pointing out some clinical pearls that will be helpful to you on your step exam and during your pimping sessions, because everybody loves a pimping session, the good old Socratic method. So we're going to talk about stages and phases of labor. These are definitions, so you need to memorize them. The mechanism of labor, which is also something that you should learn and know cold, and then how we manage labor and delivery. There'll be a multitude of other lectures that will go into step-by-step other things that you should know on labor and delivery, such as reading a fetal heart tracing. So we're not going to cover it in this lecture because that would be super overwhelming and nobody wants to be overwhelmed. So the stages of labor, so obviously we have 4 stages of labor, 4. And the first stage of labor is broken down into the latent phase and the active phase. Then the second stage of labor, third stage of labor, and the fourth stage of labor goes on until 6 weeks postpartum. So during the first stage of labor, that is when a woman starts to perceive regular painful contractions. And when we are practicing, we usually say that those contractions are less than 5 minutes apart. They're painful. They're not just a hardening and softening of the abdominal wall or the uterus really, but the woman perceives it as the abdominal wall, but it's actually pain that is associated with it. And why we need pain is because pain is what actually causes the cervix to thin out and open up, okay? And so we say regular painful contractions less than 5 minutes apart, lasting 2 hours or more. And then that is considered regular painful contraction that changes the cervix. And that stage goes all the way until the cervix is fully dilated at 10 centimeters. It's fully thinned out at 100% effaced. So I find that a lot of medical students have a problem with understanding how the cervix is modulated during labor. So what happens is that the cervix is as long as your finger, almost 4 centimeters to 5 centimeters for most women, and then it is thick, okay? And so what ends up happening is the cervix must thin all the way out till it's paper thin and must open, the os must open all the way up to at least 10 centimeters, which will accommodate a fetal head, okay? And this happens with a network of different hormones such as prostaglandins thinning out the cervix, okay? And I say prostaglandins because when we talk about induction of labor in another lecture, we will introduce you to prostaglandins, and prostaglandins help us to prepare the cervix for labor or for the induction of labor. We call that cervical ripening. So in the latent phase, we kind of have used the idea that before 6 centimeters, there is a slow, gradual, incremental change in terms of the cervix thinning out and opening up. So up till 6 centimeters, usually you see a slower progression. And after 6 centimeters, there's an exponential quickness with which the cervix goes from 6 centimeters dilated to 10 centimeters dilated. And if you went to medical school when I did, this number used to be 4 centimeters, because we used to use a different model, the Friedman model, than that what we use right now, which is the Zeng model. And so the Zeng model is more modern and is more up to date. So if you ever hear about the Friedman curve, then you most likely are talking to a physician that's using an older version of this method. The active phase is from 6 centimeters until complete dilation, and that is a much more increased rate. The second stage of labor is the actual passage of the neonates out from the uterus into the outside world. So that's from fully dilated to the delivery of the neonate. So that includes descent, where the fetus comes into the cervical canal and then into the vagina and then is delivered. And then the third stage of labor is the delivery of the infant. Is after the delivery of the infant to when the placenta is delivered. It can take anywhere from 5 minutes to 30 minutes and be a normal stage. If it is longer than 30 minutes, then it becomes an abnormal delivery of the placenta, okay? And today we are dealing with normal labor and delivery, so you need to know that. You need to know that the third stage of labor usually lasts between 5 and 30 minutes. And sometimes we deliver the placenta with gentle traction on the umbilical cord after the cord is clamped and cut. So usually if you have an anterior placenta, so you have the anterior wall of the uterus here, you have the placenta here, which is anterior, usually put a gentle downward traction until you can kind of ease the placenta out, and then the placenta comes out into the vagina and then out into your hands. It almost always comes out with trailing membranes, so we try to make sure that the trailing membranes are captured so you don't leave anything left in the body. And to do that, usually students are taught to rotate, and this is a part that you're really going to be exposed to, this part. And usually the pimping question around this, and I'm going to leave you homework to figure it out, and I want you to put it down in the chat below. The first question that I'm asking is, what are the signs of placental separation? You need to know the cardinal signs of placental separation. Many attendings will not allow you to deliver placenta if you don't know that, because you need to know that the placenta is separating on its own so that you do not cause your own iatrogenic issue. What can you cause? You can cause uterine inversion, where you pull the placenta so rapidly that the uterus kind of inverts of itself and comes out. That is an obstetric emergency because it causes a lot of postpartum hemorrhage, or it is a major cause of postpartum hemorrhage. So I want you guys to leave it down below and I'll interact with you. The fourth stage of labor is during the postpartum period. So the infant is delivered, the placenta is delivered, and now you're in that stage that the woman is recovering. And this takes up to 6 weeks postpartum. And the way I explain it to my patients is, once you deliver, all the pregnancy hormones are not just evaporated. You are physiologically pregnant until 6 weeks postpartum. And that makes sense why we have a postpartum visit at 6 weeks postpartum, because one of our goals, not our only goal, but one of our goals is to make sure that you don't have any complications like diabetes, hypertension that would develop during pregnancy, persisting past that time. And if you do, then you now become a type 2 diabetic or a chronic hypertensive or something like that, because you have passed the stage where we can blame it on pregnancy, if that makes sense. So there are normal timing. Not every physician and most practitioners, midwives, we don't necessarily go by this timing, but it's a great gauge. It's a good guideline to know if there is what we call protracted labor, arrest of dilation, if there's some kind of dystocia or problem with labor. So typically, the first stage of labor will differ between, or any stage of labor will differ between a woman who is her first pregnancy, and where they're called nulliparous women. We also call them nullips, because we're cool like that, versus multiparous patients or multips. So if you hear nullip, that's somebody that's delivering her first baby. A multip, that's somebody that's delivering more than one baby. Grand multip is somebody who's delivering more than five, who has delivered more than 5 babies, or this is her 5th pregnancy. And that kind of helps us kind of know what's happening in our heads as practitioners, because multips take less time than nullips on every single category. So in the latent phase, it is acceptable for a woman to go from regular contractions to 6 centimeters over 20 hours. So you remember your mom telling you, I was in labor for days. She most likely was in latent labor for days, or prodromal labor symptoms, or maybe she was being induced. So you should ask that question the next time your mom wants to blame her whole labor on you and your big head. So 20 hours is an acceptable time for a first-time mom, 14 hours for a multip. The active phase is when you're going from, remember, from 6 centimeters to, or rupture of membranes. So we actually count active phase also with rupture of membranes, even if it happens spontaneously, versus if we augment, or we do what we call an amniotomy, where we use a little hook and we break the bag of water to help augment labor or induce labor, depending on when it's done. Most of the time it's used to augment labor. And so you diagnose an arrest of the active stage of labor if there's no cervical change after 6 centimeters or rupture of membranes despite 4 hours of adequate contractions. And we diagnose adequate contractions with an intrauterine catheter. So you have to put, and you have to know the pressure inside the uterus. Now, most of the time when you're on labor and delivery, you see women with 2 sensors, sometimes 3 if they're twins, but in a singleton pregnancy, you see 2 sensors. One of the sensors is to monitor the fetal heart tones. The second sensor is to monitor the uterine contractions. Although you see a swelling and then a return to baseline, and a swelling and then a return to baseline on what we call the tachometer, or the measurement, the external measurement of uterine contractions, that doesn't give you an actual intensity measurement. All it's measuring is the duration and the frequency of contractions. And many times, if a woman is thinner, the sensor can get to it more. It shows more of an accurate, intensity, if that's anything to go by. But what we use to measure adequate contractions is an intrauterine. So we put a catheter into the uterus, and now we can measure the direct intensity. And basically that we will talk about in a different lecture completely, but we're measuring the Montevideo units. It's the area under the curve from the baseline to the peak of the contractions. And if that is greater than 20, then, not 20, 200. I'll say that again. If that is greater than 200, it is considered adequate. So we need to have adequate contractions, regular contractions, for 4 hours, or 6 hours of administering Pitocin or oxytocin via IV to help with the augmentation or induction of labor. And if there's no cervical change at that time, we diagnose an arrest. And all this data came from the SAFE Consortium for the primary C-sections. We want to prevent primary C-sections because when a woman has a primary C-section, she has more of a chance of having a repeat C-section, and also has a chance of having another repeat C-section. So we're trying to have vaginal deliveries. Recently I had a patient who interviewed me before she wanted me to be her obstetrician. She was already my patient as a gynecology patient, but now she's pregnant. It's her first pregnancy. She's very learned. She's very excited. She wanted to make sure that I was the right person for her, and thank God she chose me. And one of the questions she asked me is, what is my C-section rate? And the truth of the matter is, C-sections are a viable and many times necessary way of delivering a baby, because there are some preclusions to having a vaginal delivery, such as having an active herpes outbreak, because we don't want to expose the infant to herpes in the birth canal. Sometimes the infant is not head down, and sometimes it's transverse or oblique or breech, and those increase the risk of head entrapment. So once the body is delivered, especially if you try breech delivery, there's a increased risk that the head gets entrapped in the cervix, and that is not great. We didn't accomplish anything. So we most of the time opt to go for a cesarean section. Sometimes there is a need for a cesarean section when there is a plummeting or an abnormal fetal heart tracing that tells us that the infant is not able to tolerate labor. Sometimes the woman's pelvis is not able to accommodate the size of the infant or the fetus that she's carrying. So there are many reasons why we decide to opt for a C-section, but I am not one of those people that opts for a C-section just because it's Friday night and I want to party. No, we have to make good decisions for our patients. And so these guidelines have allowed us to counsel a patient as to what is tolerable and what is not tolerable. Again, these are guidelines. There are things you have to memorize, but you might see, and I hope you do see, some physicians who tolerate labor a little bit longer and don't go straight for a cesarean section. So a normal rate of dilation is, I really just say 1 centimeter an hour when you're in the active phase, but the actual number that you need to memorize, that I need to memorize for my boards, are 1.2 centimeters an hour for a first-time mom and 1.5 centimeters an hour for a multiparous woman. So that was for the first stage of labor. Now for the second stage of labor, which, remember, is when you are completely dilated until the delivery of the infant. And so that is the pushing stage. And so the second stage of labor is prolonged if now we have to categorize it not just based on the gravida and parity of a woman. It wouldn't be just nolib and multip. It now will include whether or not the woman has an epidural. So epidurals, we give the woman an extra hour because it prolongs pushing. And that has been shown in the literature. So with an epidural, 3 hours of pushing with a nolib is considered normal. It is prolonged if it is longer than 3 hours with a first-time mom, longer than 2 hours with a woman who's had a baby in the past. And this has to be really good effort, really engaged effort. So that's something that you will see that the residents or the attending is going to be checking to make sure, or the midwife or any other birth attendant is going to be checking to make sure that the pushing is engaged, it's strong, it is committed, and it's going to push the infant or make the infant change the station and come out at a regular period. Sometimes you'll see that if a woman was not being augmented with Pitocin, she might be, to allow for regular contractions so that the pushing has a concerted effort. And then without an epidural, we shave an hour off of each allowance. And so the rate of descent should be at least 1 centimeter an hour for either one, like multip or nolib. So third stage of labor, we already discussed, that's the delivery of the placenta. It's about, the average is about 5 minutes. It's prolonged if it's greater than 30 minutes. So that was the stages and phases of normal labor. So what is the mechanism of labor? And the mechanism of labor, we kind of talk about the cardinal movements of labor. These are the changes of the fetal head as it goes through the passage of the canal. I will recommend that you just memorize the actual sequence of events. So first of all, there has to be engagement. That is when the bipyramidal diameter of the fetal head is below the pelvic inlet. And so that is the definition of zero station. So what we do is we find the bipyramidal head. We make sure that the lowest part of the occiput is at the maternal ischial spines. So you'll see the resident checking that, or you'll see the attending checking that. And then after the head is engaged, there is descent. And then after descent, there is flexion. And that allows the smallest part right here of the suboccipital bregmatic diameter, it passes through the pelvis. So this happens, this is just nature. No one learns this. So there's engagement, there's descent, there's flexion, there is an internal rotation. It goes, and then there is an extension of the head, and then there is an external rotation, and then there's this expulsion. And you'll notice after the anterior shoulder is delivered under the pubic symphysis, the rest of the body, boom, right out. So the first time you see a delivery of a baby, sometimes you might see this, like you'll see the baby's head doing all of the cardinal movements of labor, and it's a beautiful sight. Every single time, I've delivered hundreds of babies, but every single time I see this, it is always I'm always in such awe, because this is nature at its finest. This non-taught behavior. This is completely nature. So when you are admitting somebody to labor and delivery, these are the things you need to know. And this is what you need to know as a student. This is where you get to shine. So a lot of times we allow you to go into labor and delivery and go into triage and get this information, or when somebody is pre-admitted, you get this information. So you want to get a history and physical. You're always asking the 4 questions in the HPI. And the 4 questions are contractions. How frequent are you getting them? How long have they lasted? Are they painful or are they non-painful? Do you have leaking of fluid? And most patients don't know what leaking of fluid means. So you say you have clear water, pink tinged water, light green water coming out of your vagina. And do you think your bag of water is broken? Those are all ways to ask that question. Do you have vaginal bleeding? And the vaginal bleeding can be spotting, especially if they're checked in the office, if they just recently had sexual intercourse. So those are 2 questions you always ask as a follow-up question with vaginal bleeding. But if it's heavy vaginal bleeding, and we will talk about 3rd trimester bleeding and what it means. And then lastly, is the woman feeling the baby move regularly like she always did? Because this will help us put her in different categories. And of course, before that, you're going to know age of the patient, gravity and parity. Gravity and parity we talked about in the last video. And then for each one of her previous pregnancies, you want to go through and document that. Why does that matter? If this woman has had 2 prior C-sections, she's going for a C-section, right? There is part of, there's a debate, there's a lot of, but most places, most hospital policy is that 2 C-sections, you're going for a C-section. And the follow-up question should be, when last did you eat? Because that helps us know, that lets anesthesia know when this C-section can go back, because we want to prevent aspiration. And so we don't want to get back. We're trying to have a C-section with regional anesthesia. Something happens, we have to intubate this patient, and her food is right there, so she aspirates. And that's not good. So that's why we ask that question, when was your last intake? That will make you a start every single time. And if she had a prior C-section, just one, ask her if her provider and her had discussed a repeat C-section or a trial of labor after cesarean section. And the trial of labor is different from VBAC in that trial labor is a trial. VBAC is the success of the child, or vaginal birth after cesarean section. So a lot of people ask the question, what does that mean? Okay. And then we also want to ask the weight of the previous pregnancies, because and you want to know if a woman was able to accommodate a 10-pound pregnancy in the last, or a 10-pound baby, her pelvis was able to accommodate that. Well, if this baby is 10 pounds, she has what we call a proven pelvis. And then with the physical exam, make sure you pay attention to the vital, particularly the blood pressure, but that is not it. Pay attention to her heart rate. Make sure she's not febrile, because sometimes people are coming in for what they think is labor, but they really have a UTI. They could even have pyelonephritis. They could have appendicitis. They have so many other things, because you're pregnant you don't cease to be human. So don't always get so narrowly focused on labor and delivery, especially when the woman is not full term. And again, term is 37 weeks plus. And then look at the fetal heart tracing, which we'll talk about fetal heart tracing in TOCO and how to read it in the next, in one of our subsequent lectures. Try to do the EFW. And I used to learn how to do this because one of the things I did was carry a 1 pound bag in my arms and figure out what 1 pound is, and then try to figure out what the EFW is. An average EFW is 3,500 grams. So you could try to use that and determine, do you think it's bigger than 3,500 grams? Do you think it's smaller? If, as a student, resident, intern, always try. You might be completely off, but always keep that, what you guess, and correlate it to what the actual, so that you can start to learn and get a feel for what is the actual weight and how to do an EFW. Looking for the presentation, you want to feel and see if you can feel a butt, a head, nothing, how you feel it. These are Leopold maneuvers that we use, but a lot of people just use ultrasound. You look to see the head, look to see where the placenta is, look to see the fluid around the baby. You can measure either a full AFI or a maximum vertical pocket. We'll talk about that ultrasound on labor and delivery in a whole different presentation. And then and then after that, if you're a student or intern, you probably will be waiting for your resident or attending, and then they will be doing either a sterile speculum exam if there's leakage of fluid and they're trying to figure that out, or a sterile vaginal exam that is digital, or both. And then you would order the labs that you need if you're keeping the patient, if you're sending the patient away. Now this starts to get categorized. And then you make sure that the patient has IV access if they're staying, or if they need to get hydrated. If we think this is not true labor and we're trying to hydrate the patient quickly with IV hydration or IV fluids. And then, so there are many things we're going to discuss separately. We're going to discuss how to read a fetal heart assessment, a TOCO or tachometer, the operative vaginal and C-section. We're going to do all that and inductions separately. So that's it. So I think that's it. So let's summarize. We just went through normal labor and delivery, and I want you to learn the stages and phases of labor and how long they last. These are questions that are easily asked on a written exam. They're easily pinned. Know the mechanism of labor, just the steps in which it happens, and then know how to do a triage. So there's really 3 things we learned today, and I'm looking for homework from you. I want to know what the stages of placental separation are down in the comments. It's been so good talking to you. I'm going to stop sharing the screen now. It's been really good talking to you. Again, my name is Dr. Ruth Arumala. I encourage you to join us in a lot of the things that we're doing. Listen to the Pretty in Pink podcast. Ask me for a topic you want to learn. I'm going to be going through a lot of the basic topics in OBGYN, and we're going to be learning together. It's going to be a beautiful time. I'm so excited for this semester that you're in, and I know you're going to do great. And if you're going to be a future obstetrician, you might be delivering my baby, so got to make sure that you're well trained. Take care and stay safe.